All right, with that, Dr. Medina, do you want to start with our COVID-19 updates?
Thank you so much. All right. Well, almost 2.5 years into a pandemic, we keep talking about this because it keeps being important. I'm going to try to be as efficient with my time so that we're not late. So I'm Luis Medina. I'm a medical director of telemedicine services at UMC. I'm an infectious disease physician, community faculty with UNLV, and we're going to talk today about COVID-19 variants, statistics, and treatment updates. Next slide, please. Our learning objectives are to provide an overview of the evolution of clinically relevant SARS-CoV-2 variants of concern in the US, to discuss national and local disease statistics. We'll talk about the silent wave that we're undergoing, crossing the threshold of 1 million deaths in just over 2 years and why we must do better, vaccine updates in the context of Omicron and more, treatment options and where to find them, and something about long COVID, not just the flu. Next slide, please. So COVID-19 variants. I put this here because it's a nice little picture of the virions. And if you notice on the spike proteins, they change colors within the virion. And then you notice that by the time you get to Omicron, you have more colors and then several colors within each spike protein. And that's just nature telling you, I am going to survive. And so before we run out of Greek letters on the alphabet, this company called Pango started the nomenclature for the different lineages of COVID-19. And you could note here that at least in the Omicron variant, you have at least 30 mutations there, but it's really close to 50 plus mutations as compared to the original strain, so the native strain. And this is in 2.5 years of fairly uncontrolled spread. And that's what viruses need to get better and stronger. So we're in Omicron, and there's at least 5 sublineages of Omicron. We'll talk a little bit in the next slide about BA2, which is now the dominant variant in the United States. Next slide, please. And so we've seen slides like this before. This is data from the CDC COVID data tracker. On the left-hand side, you see these bar graphs with different colors. The purplish bars, which were dominant near February of 2022, are the BA1.1 variant. And as time has gone by, you could see that the pink, namely BA2, is dominant and now is representing more than 50% of the cases in the United States. So it's now officially the dominant variant. Now, why is this important? Well, because even though the clinical presentation of COVID cases with these variants aren't more severe, they are more transmissible, and they have developed escape mechanisms against vaccines. So that means that as time goes by, with progression into new variants, our vaccines will become less effective. Next slide, please. And so talking a little bit about statistics, this looks like a busy slide, but I'm going to break it down fairly easily. I want you to see this in the context of the national temperature of how we feel about COVID, right? And the feeling across the board is that we're done with this pandemic. But I will remind painfully everyone that this pandemic is not done with us. So we had a very beautiful honeymoon period over the past couple of months where cases were very low, but here you could see in the upper left-hand side, new cases in the United States are averaging about 100,000 new cases a day, 280 deaths per day, which are 280 too many. And you see a steady rise in hospitalizations averaging about 3,200 a day. When it comes to vaccinations, 82% of the population have at least received 1 dose. But you could see that that is really not enough. And so coming to data from Nevada, I was sad to see the reporting of positivity rates go away, initially from the daily reporting, then to the weekly reporting, then to no reporting. And I understand the context of, how do you compute for those home tests that are not reported and how that's going to skew the data. But the CDC has found a way to calculate that in Nevada, 20 to 25% positivity rate is probably where we're at. And on the right-hand side, you see that green graph that has that Omicron wave in January of 2022, and then that sweet honeymoon period where there was a lull, and then you see that precipitous rise again in positive cases. And so our data doesn't reflect that because we don't report it, but it's certainly happening. It's just we can't see it. And so the sad part for me is that it blinds us to action, right? You're flying a plane with no instruments, no visibility, and that makes it very difficult to make good decisions in a short period of time. And the left lower quadrant there has a comment that says, why is the community level low, right? We went from the whole country being red in my last presentation to everything being green and staying green, and now finally changing. So the rationale behind that is that the community level is low because the levels of COVID-19 hospitalizations, cases, and patients in hospital beds are not a strain for the local health system. And that little wondering emoji is meant to tell people, yeah, that is not mean that it's not a dangerous situation. And just because we could handle it, we're able to handle it now, doesn't mean that we won't be overwhelmed again at a moment's notice. So we should be mindful of that in the decisions that we make. Next slide, please. And this is really a powerful slide for me. The United States has the world's highest recorded death toll from the virus, and it got there in devastating speed just 27 months after the first case was confirmed in the US. So the first death was in February of 2020. By the end of that year, you had 250,000 deaths. And if you go back to the beginning when Dr. Fauci and Dr. Birx were on TV, they found it difficult to believe that you'd get to 250,000 deaths. By the end of 2021, you've had 750,000 deaths. And just a few months after, we've hit the 1 million mark as it pertains to deaths. So this is very much not over. Next slide, please. And I think this is impactful for me, the context, right? You think of 1 million deaths and you become desensitized as to what that truly represents. And so what does 1 million people look like? In the perspective of populations, Rhode Island has 1.1 million inhabitants. Montana, Delaware, San Jose, Acapulco and Magneto, Mexico has 1 million people. Austin, Texas has 1 million people. Imagine the populations of those states just dropping dead all of a sudden. It is a huge amount of deaths, many of them unnecessary in the era of vaccines. I like this phrase for Dr. Cindy Prinz. Those are 1 million loved ones. Every one of these people has had a face and a story and people who cared about them and lost them. And data from CDC reports that COVID-19 is now the 3rd leading cause of death in the United States. Just let that sink in. Next slide, please. But we're not powerless. Vaccines are still effective. This is a paper that was published in the New England Journal of Medicine in early March of this year, looking at vaccine effectiveness against symptomatic disease according to the time of vaccination, and they looked at over 2.5 million people. They studied 2 vaccines, the Chadox or the AstraZeneca product from England, and then the Pfizer-BioNTech vaccine in the context of the Delta wave and the Omicron wave. And so when you look at the data from AstraZeneca, initial vaccination provides 82% protection against symptomatic disease, and it wanes with time. They gave these people a booster with a Pfizer shot and it significantly increased their protection levels, but it does wane with time. And similar findings were seen in the Pfizer-BioNTech arm. So what to note here is that the initial protection is very good, but about 25 weeks or so in, it is significantly reduced. And you can see a marked reduction in protection in Omicron as compared to Delta strain, which is just another testament of virus fitness and change. Giving them a booster dose later then brings that up, but it's not as good as we would like it to be. Next slide, please. But even though you have significant decrease in prevention of symptomatic infection, the vaccines are still highly effective in preventing severe disease, hospitalizations, and deaths. So this is a publication from CDC, Morbidity and Mortality Weekly Report. This was from February, and it showed that even though there's waning protection, it prevented emergency room urgent care visits and hospitalizations in 87% and 91% respectively. So even though you have so-called breakthrough infections, the vaccines remain highly effective in preventing hospitalizations. And that's why we should still get all the benefit of it, and people should continue to get vaccinated. Next slide, please. And so let's talk now about treatment. This is a wonderful 2-hour webinar from IDSA, aired on March 12th of 2022. You're welcome to watch that. And it's a whole bunch of experts talking about where we were only a couple of months ago. We'll briefly summarize that in the next few slides. Next slide, please. And so the overall important message to convey is do not delay testing, because testing early, diagnosing early is going to allow you to refer patients that are appropriate for treatment to treatment. Remember that there is a therapeutic window in which to offer oral antivirals and monoclonal antibodies, and then IV antivirals like remdesivir. And so using these therapies has significant positive effect in these patients. And what you want is to prevent them from getting severely ill. But if you don't test, you don't know. We learned that painfully at the beginning of the pandemic, right? Clinical scenario does not help. You have to test. Next slide. And so the CDC gave this health advisory, the Health Network, a couple of weeks ago, and it was updated information on availability and use of treatments for outpatients with mild to moderate disease. So that's what we're going to talk about in the next few slides. Next slide. 6 recommendations were notable. 1, maintain yourself updated on information. This continues to change very quickly, and you need to be in the know. Number 2, prescribe treatment for COVID-19 in patients that have clinical indications for it. Number 3, know where to find these treatments. It is only useful to know that you can treat somebody if you can point them to the right direction on where to get treatment. And for you to do that, you must know where this is made available. Number 4 is do not use steroids in patients that don't need oxygen. If they are not sick enough, they can actually be harmed by steroids. So don't use them when it's not appropriate. Don't use antibiotics is number 5, in the absence of another indication. I know that our fear of missing something, i.e. a bacterial infection, almost compels us to order antibiotics on patients. But when you know that the symptoms are due to COVID because you have a positive test, treat for COVID and trust that you're doing the right thing. And finally, to encourage patients to complete their vaccination series and to stay up to date, i.e. if you're eligible for a booster, please encourage people to go get it. Next slide. So these are the NIH recommendations on treatment of patients that do not require hospitalization or oxygen as outpatients. So you have 2 preferred therapy. Paxlovid, which is ritonavir boosted nirmatrelvir, and that has a high recommendation, A2A. And then second option is remdesivir. And then alternative therapies, meaning when you're not a candidate for the preferred therapies or they're not available, then you use bebtelovimab, which is a monoclonal antibody, the only one with activity against Omicron. All the other monoclonal antibodies are out for now. And then molnupiravir. And this is, not the preferred drug because it's significantly less performing than Paxlovid, but if you have no other choice, I think that's reasonable. And again, they recommend against the use of dexamethasone or other systemic corticosteroids. We'll talk about provider resistance to providing Paxlovid and how to fix that. Next slide. And so this is very important, right? We want to know where to find the treatment. And the Office of the Assistant Secretary for Preparedness and Response has this beautiful website where you can log on, put your information as to where you are located, and it literally helps you find a treatment center that has the drugs that your patient needs. So this is how you find out. This is probably the easiest way to find out. Next slide. And look at this. You look at that map of the United States and it is almost completely blue. That means that even in Hawaii or remote Alaska, there's treatment available. And it's nice that it gives you, how many doses are available of each of these treatment agents so that you know that there is treatment available. Next slide, please. Now let's talk briefly about prescribers' anxiety with giving Paxlovid in the context of over 100 drug interactions. Well, the IDSA took the task of sorting all of this out. And there's really two absolute contraindications of prescribing Paxlovid, and that is in patients that are anticoagulants with rivaroxaban due to increased bleeding, and those that are on salmeterol because of increased cardiac effects. And so outside of those two drugs, you can pretty much tailor therapy, right? You can offer them treatment with Paxlovid, hold the other medications, monitor for side effects. The benefit that they will get, especially if they're high risk from antiviral treatment, outweighs the risks of medication interactions. And if you're extra OCD, go to the University of Liverpool website where they have a COVID-19 drug interaction checker, just like you would in other websites for other drugs. You put in what drug you want to give them for COVID, you put in the other medications that they're on for their chronic illnesses, and it'll flag things that need attention. So use it, prescribe it, save lives. Next slide, please. And even though we're not going to focus on inpatients, this is just a recap of the inpatient treatment of hospitalized patients. Again, do not recommend steroids for those that don't need oxygen. If you do need oxygen, use remdesivir, especially if it's within those first 10 days. You can use that in combination with steroids when appropriate. This morning, the results of the Act 3 trial came out, and it suggests that the use of not tocilizumab, but baricitinib is actually superior to steroids. I'm sure that will need to be replicated before people actually make that recommendation change, but it was a statistically significant higher chance of having side effects with steroids than with baricitinib. And the sicker you get, really the less options you have for antivirals, and you have to focus more on the exaggerated inflammatory response to get these patients in trouble. So the Dexa, the Toci, the Sarilimab, when you don't have the other drugs available. Next slide, please. And finally, I want to touch briefly on sequelae of COVID. The perception that the milder presentation clinically of the Omicron variant makes it any less dangerous is a dangerous proposition. And so many patients, even with mild clinical presentations, have long-lasting effects. The CDC, NIH, I think, just came out with that report that say that about 20 to 25% of all patients that recover from COVID have at least one long-lasting symptom of the disease. And if that is fatigue, it sounds like something that's not too bad, unless it's severe fatigue and unless that's you. So you could have a ton of different symptoms. Some of them can be very, very difficult, like post-exertional malaise, that just don't seem to go away, and that they get worse in the context of even minor physical or mental exertion. And they can last for days or weeks to recover. So definitely not dangerous. And the best case scenario is don't get COVID. Next slide. And it is still an area of little data. There's a huge void in our knowledge base of long COVID. The NIH has a huge program called the RECOVER program, which is a national program looking into investigating the causes of long COVID and then treatments that may be effective. More than 500 million people around the world have had COVID, and millions of them will probably have long-term effects of that. In the context of the US population, American Indian, Alaskan natives are 3.1 times more likely to suffer from these issues. And then that's true also for other people of color like Blacks or Hispanics. This is also more prominent in women than in men. And, you know, the best thing to do is to not get it if you can. So vaccination has also shown a positive correlation to not developing long COVID. So that's another good reason to get vaccinated. All right, and I believe this is my last slide. And I thank you so much for your attention. This is just a recap of what we went through. We talked about the evolution of variants and those that are clinically relevant. Talked about statistics, both nationally and locally in our silent wave, why we must do better because this patients can be one of us, right? It could be ourselves or it could be one of our loved ones. So we must do better than we have done before. Try to take politics out of it. Vaccine updates, you need to get vaccinated because it's still helpful. And then the other thing is, if you need to wear a mask, be wearing a mask. You know, you can wear a mask whenever you want to wear a mask. Treatment options are so important, but not more important than where to find them. What's good to know is what to do if you don't know where to get it. And then don't undercount long COVID. It is not just the flu. You don't want to get it. So that is my presentation for today. Thank you so much for your attention and time. And I'll take any questions as they come.
Dr. Medina, there's a question in the chat.
Yeah, that's a question. Thanks, Dr. Palmer, from Crystal. With the rate of mutation, would getting a booster every 6 months be better or use adjuncts such as Emergent to help?
The timing of supplemental doses of vaccination is difficult to elicit, right? There's people that have gotten 5 doses, 6 doses, because they think that it'll make them more protected. There was a question of that 4th dose for healthcare workers. They did a huge study in Israel, and they compared healthcare workers who had 3 doses versus healthcare workers who had 4 doses, and the difference in protection was not statistically significant. And so if you're not at particularly high risk, you know, more doses or more frequent doses will probably not be as helpful as we would like it to be. In the case of Evusheld, which is a monoclonal antibody that is used for prevention of COVID in patients who do not mount an immune response that is sufficient, like those with B-cell issues or active chemotherapy, it does help. We found out that you needed a higher dose than initially recommended, and it offers protection for about 6 months or so. And so it's not for everyone. I'm sure that with newer variants, it probably will lose effectiveness, just like the other monoclonal antibodies that we've had in the past. And then, you know, this leads to, what are we going to do then if the things we do now stop working? And so the answer to that is probably the development of a pan-coronavirus vaccine that targets a conserved region of the virus that doesn't mutate as easily. And so they're working on that already. There probably will be, by the beginning of the summer, updated vaccines, mRNA vaccines against Omicron and its subvariants. But really, the development of a pan-coronavirus vaccine will be the holy grail, because, you know, that way you only have to make one ring to rule them all. And then the next question was, for those that receive the J&J, can you get a booster with Moderna and Pfizer? Absolutely, you are correct. You can get a booster with either one of them. Next question was, does treatment decrease long COVID? And so, excellent question. Even though patients with mild illness do get long COVID, there is a correlate of protection from treatment. So the patients that have more severe disease are presumably having higher viral burden. So the more copies of the viruses that you have in your body during infection, the higher the risk of you developing long COVID. So if you intervene early with an early diagnosis before you hit that peak of viral burden, and I don't want to say viral load because that just confounds it with HIV, you do decrease the risk of developing long COVID afterwards. So that's another positive point of saying, don't treat, let nature take, just do something. It's better than doing nothing. So yes, it does decrease that risk. And then the next is, can you comment on rebound with oral Paxlovid? All right, so the CDC just had yesterday, I think, another HAN on rebound with Paxlovid. So what they're saying is, like, look, the recommendations is test early, and if you're within that 5-day window period of treatment, which is the treatment window, offer them Paxlovid. So patients get better fairly quickly. I've prescribed a significant amount of Paxlovid, and about 24 to 48 hours after starting treatment, most people feel significantly better. But there's started to be a lot of reports of patients getting clinically worse after finishing the 5 days of treatment. And the question is, what does that mean for, you know, the reality of it? there was a press release by the Pfizer CEO that said, oh, we'll just give you another 5 days of Paxlovid. And that's just not supported by science. That's not how this process works. And the recommendation officially from CDC and NIH are don't do that. The question then is, if you are symptomatic again, is it a recurrence of viral replication? And the answer to that is probably yes. The answer to are they infectious again after the rebound has not been answered. But while we figure that out, the official recommendation from CDC is isolate again, mask again. So reset the isolation period, if that answers the question. They're looking into the causes of that and what that actually means, but not ready for prime time yet. And then the next one was, do you know of current recommendations for COVID positive pediatric patients less than 5 years old? Sadly, outside of severe illness with hypoxemia, there's nothing other than remdesivir that you can give them. In the outpatient world, you have nothing to give them. There's nothing for you to give them. Luckily, after 1 year old and to 5 year old, they rarely get severely sick. It does happen, but it's just not something that happens often enough. That high risk is from neonates to 1 year. In those cases, you probably could bring them to the hospital and consider giving them remdesivir. I'll let the pediatricians comment on that because I am not an ID doctor for kids. But sadly, there's nothing else you can give them. Hopefully by mid-June, we'll have vaccines available for them. That data from Pfizer is looking pretty good, but it has been delayed before. So we'll see where that goes. And then the next question is, if the disease is mild, should they be treated to decrease long COVID? In the case of adults, I think if you have risk factors for progression to severe illness, I would say definitely treat. For not just to prevent long COVID, but to prevent progression and severe illness and hospitalization. You are correct, but we have seen MIS. Absolutely. And so MIS-C is a multi-system inflammatory syndrome in children, and that usually happens about 4 to 6 weeks after they have recovered, even from a mild COVID infection. And it's pretty scary. I mean, these kids show up with heart failure, with kidney failure, with liver failure, end up in the ICU. Super scary picture for the doctors and for the parents. Most of them make it out okay, but again, it's a gauntlet. And if you can prevent kids from getting MIS-C through vaccination, which vaccination showed to reduce the risk of developing MIS-C in 91% of cases, that was good enough reason for me to vaccinate my kids.
Great. Thank you for that, Dr. Medina. I don't think we have any other questions. So in the interest of time, I'm going to go ahead and enter
You're muted, Vicki.
I just realized that. My apologies. Thank you, Dr. Palmer. In the interest of time, I think that's our last question. So I'm going to go ahead and share my screen now with our follow-up information. And I've also placed this information in chat, but first link you see there in chat and on my screen is the link to our Emergent Infectious Disease and Public Health Threats webpage, where you can find information and resources. The next session is set for June 22nd at 12 p.m. As always, we ask that you please complete an evaluation. Let us know how we're doing, information or topics that are important or an interest to you, and let us know how we can better help you moving through this ECHO session and to claim your CMEs. The code to claim CME for today is 8187. If you'd like a copy of the slides from today, please visit our reference resource box at the Nevada box link that is in the chat. And last but not least, just as Natasha did today, always please consider submitting a case for us to help review during this session and help you in the important work that you are doing in your community. So please consider submitting a case. If you would like to do so and you have questions, please feel free to reach out to me or anybody else on the hub, that ECHO Hub team, and we will assist you with that. With that, thank you everyone and have a fantastic day.